Bryce, you're letting everyone in.
I just need to get some of these things off that are notifying me of.
Oh yeah, no worries. Hi everyone, we'll get started in just about a minute or so. We'll let a few more people join in. Okay. Well, it is 12:15, so why don't we get started? We are here for session IC 23, which is guidelines for ALS therapeutic interventions and plan of care. Our presenter today is Susan Calyer, and she just asked that everyone put their questions in the chat, and she'll have some time towards the end of her hour slot to answer everyone's questions. But if there's any immediate needs, I and our monitor will be monitoring that chat. And at the end of the presentation, we'll announce the CEU code, and I'll put it in the chat as well. So I'll let Susan take over.
Okay. So this is titled Guidelines for ALS Therapy Evaluation and Plan of Care. And I put in there the acronym that most people use for PALS, which is your person with ALS. I'm hoping our Zoom meeting is going to go as well as it appears that one did. That was March 23rd, 2 years ago, almost, when COVID first started. So I'm trying to interject some slides in here just to break up the monotony of a full hour-long lecture. So what I'm going to focus on for this lecture or presentation, I'm going to talk a little bit about some of the basic things like diagnosis and causes, medications, symptoms, that kind of thing. But I know that you can look all of that up. I did a presentation a couple of years ago and found myself bored with it. So I decided to do something different and really focus on what are the problems that you see and how you can help. Unfortunately, I don't have a lot of references for this kind of information that I'm sharing because most of it's just your experiential clinical experience. I'm just presenting this because the blue cornflower is something that's supposed to be just an awareness symbol. So if you see someone with a cornflower on their lapel or a pin, you might recognize that as someone who has ALS. Uh-oh, I'm not. For some reason now my slides are not moving. I am frozen.
Are you able to click on the screen at all? Does that move it forward?
No, nothing's working at all. I have no.
Bryce, any suggestions?
It's not even allowing me to escape out of here. Nothing in my Mac is working right now. Let's see. Nope, it will not forward me at all.
All right.
Okay. Obviously, if I'm having the ability to hear you, it can't be my Wi-Fi. I don't understand what's happening. I'm very sorry.
Ah, there we go. All right,
okay,
Susan,
great.
Take over.
Sorry about that. So the ALS TDI is a therapy Development Institute. These are just basic stats. 1 in 400 people will develop ALS in their lifetime. Estimated that about 30,000 people in the US will have ALS at any given time, or about 450,000 people worldwide. And every 90 minutes, someone dies from ALS and someone is diagnosed with ALS. There's actually a website called Every 90 Minutes. So I'm going to speak a little bit about criteria for diagnosis, phenotypes, and past medical history. So diagnosis of ALS can take many years. It's a diagnosis of exclusion. Typically, we'll see people needing second or third opinions, and we encourage it actually. A nerve conduction study, EMG inconsistencies are what typically kind of tip the balance in the positive direction for ALS, and sometimes they'll have 2 or 3 of those studies. Sometimes we see people who have had unnecessary surgeries, like typically it's an orthopedic condition. They have carpal tunnel syndrome, they have some laminectomies, or stenosis is seen and it's kind of blamed on that. But that's important to know when you see that the date of onset and the date of diagnosis is typically at least a year, or if not, 2 or 3 years apart. And that's important when you're considering progression and prognosis. Typically, a patient's initial symptoms when they begin the disease, the onset of their symptoms, is going to follow the progression of the weakness and the disability that it will take. We talk to our patients a lot about the 2 things that they can control, which are their weight, their overall BMI, and their respiratory device use. This is just a fun slide because I wish that we were here in Pittsburgh. I grew up in Pittsburgh, and every time I go to the ISS, I always enjoy going back. I'm an avid sports fan, and I wish we were there now, but from the comfort of our homes, I guess, this is just fine. So the causes, the theories behind potential causes of ALS, the exact cause of ALS is unknown at this point. There are about 10% of the people who have been diagnosed with a familial form of the disease, and that's due to a genetic mutation, and they've identified 2 genes, but we don't really know if there's more than 2 genes, and the other 90% are, it's just unknown. So there's theories, multiple theories. We've had people working for years and years to find commonalities like environmental toxins, occupational hazards, where they work, where they live. So far, the evidence is really unclear, although they have very relatively recently discovered that there is definitely a link somehow between having served in the military and developing ALS. I always ask my patients if they have a history of concussion or a major electrical shock, because that seems to be really, there's a high prevalence of that, including being electrocuted by, like struck by lightning, or electrocuted where it knocks them out. Someday I'll be doing a study on that. A lot of people have had heavy metal exposure or pesticide or herbicide exposure, but there's no studies that can prove it. And we even tried to do a geographical study, and I know others have. There's just too many variables, like how long did they live there? Where did they start living? Where did they grow up? So it just has not proven statistically significant. One of the things that, no, I'm sorry, I didn't start my video. Hold on, I don't know that I can get to it. One of the things that they talk about that can be difficult, could be considered a type of insult to the, here we go, get my video started. Sorry about that. So one commonly held theory is that there's some sort of insult to the system that causes or triggers the disease, including the things that we talked a little bit about, the toxic exposures to herbicides and pesticides, cyanobacteria, the blue-green algae. There can be an oxidative stress, glutamate toxicity, Sometimes it's even a trauma, like a major electrical shock, multiple concussions, car accidents, that kind of thing. Okay, so now I cannot advance my slide again, that I have my video going. I'm not sure. Oh, there we go. Okay, so now we're too far. Here we go. Okay, these are the phenotypes, or the onset and typical progression. You'll see the first one is spinal onset, and that's usually called limb girdle. The second is bulbar onset, and it's really only shaded up around the nose and the mouth area, indicating, and the neck, swallowing and speech. However, if you have a bulbar onset, it usually is your whole respiratory system impeding and impacting your diaphragmatic strength. And then less frequent presentations are progressive muscular atrophy, primary lateral sclerosis, which is also called PLS, and that typically will evolve at some point multiple years later into ALS. Pseudo polyneurolytic ALS, hemiplegic, flail arm, and flail leg, all typical, but not as commonly seen. This is a picture of one of my patients who is 34. He just recently got married, and we loaned him a wheelchair from our from our loan closet, because he's still waiting for his he was at that point barely in the process of getting one because it was so quick. They moved up his wedding, and I just wanted to point out how much different his wedding pictures look using the seat elevate feature on his wheelchair, as opposed to if he were in a chair that didn't have that feature, or if he were just sitting in a manual chair. Okay, briefly, the influence of past medical history and how it impacts. So this is going to sound a little strange. Obviously, COPD is going to negatively affect their lung function. However, if someone has cardiac disease, it doesn't seem to really impact their progression or their final outcome, because it typically is the diaphragm that's affected. However, a very healthy heart can positively affect longevity, excuse me. Obesity can positively affect longevity. People need that extra weight, that excess adipose tissue. Being severely obese, not so much, but in general, any BMI over like 25, 26 is considered obese. So someone who has a little extra weight on them typically does well. On the other hand, someone who presents with a lean body type at diagnosis, or loses too much weight too quickly because they can't eat or swallow very well, because their breathing is impaired and they're constantly burning calories, can negatively affect longevity. So we talk a lot about eating a lot and eating high fat, high protein, lots of calories for your buck. Concussions or TBI can increase the risk of cognitive impairment during the progression of the ALS, and any surgery or trauma can negatively affect the weakness or progression of that particular area, including if somebody waits too long to get a G tube, that can overall impact their diaphragm and their chewing, swallowing, eating ability to manage the calories they have. Or for instance, someone who walks for too long and does not use any devices and has multiple falls, that impacts negatively. After 70 years, we still only have 2 medications that can be used for ALS. Radicava, which typically requires a port and or significant commitment of time, and the efficacy has recently been questioned as to whether it's really doing much of anything. And Rilutech, typically most of the benefits for Rilutech are seen when it is begun in the very early stages of the disease. However, we see a lot of people with generalized feelings of malaise while they're taking it, and it really only extends life by 3 months or so with no change in symptoms. So end of life, 3 more months. But if you're completely paralyzed at that point, then you're still going to be completely paralyzed. The rest of the meds that we use are aimed at symptom management. So some that help with decreasing saliva production because it doesn't make you increase your saliva production having ALS, but being unable to manage your saliva or aspirating on your saliva can be an issue. Also, we talk about medications for spasticity, which is an upper neuron sign, and it can be awful to control. Medications aimed at hypersensitivity and pain. Infrequently, but sometimes people will present with pain type syndromes as a presenting symptom of their ALS, like a hypersensitivity almost. But it, to me, it almost feels like the body is interpreting this nerve insult as pain, but it's not. It's the ALS trauma to the nerves. And also pot, which is also known as the medication that my Catholic hospital won't let me talk about. However, in this tattoo picture that I love, Tattoo Fails, where the guy had regret knowing tattooed on his arm, I won't regret talking to any of my patients about having ALS and using medical marijuana. Many, many, many compounds inside that drug can be very beneficial. One of the big issues is the cost, of course. Also, if you're just using it over the counter without going to a medical dispensary, if you live in a state where it's not legalized yet, you don't necessarily know how much THC or CBD you're getting, so that can be a real problem. It's a depressant, so it can cause mental health issues and overall addiction issues for some people. Although that's not necessarily something we worry too much about. The other thing is a lot of people will say, I don't want to use medical marijuana, I'll just use CBD, which can be very beneficial. However, if you need it for certain symptom management, you really need to have both the CBD and the THC, even if it's like 1:20 ratio. Some of the pros, and the next slide gives you what the THC and CBD does, but it can alleviate pain, can help with your cramping and spasticity, improve your appetite. And if you grow it from seed, which you are now allowed to do in New York State where I live, you can buy seeds where you know the chemical composition. This is not a great slide. I'm sorry. This was from a presentation that was given to us by a dispensary. And you can see on the left side, it shows you the THC, and on the right side, the CBD, and what it generally will give you in terms of symptom management. And just so you know, if you haven't already seen all of my slides and the document from which I made this keynote, they're all available to you online, so you don't have to worry about writing anything down. So this is just a monotony breaker. I just saw this in December and thought, geez, that sounds about good. Okay, so there's a couple of other concurrent conditions that I think you need to know about. One is called FTLD and one is PBA. So pseudobulbar affect, PBA, it's commonly seen with ALS, sometimes up to 40%, causes a person to have uncontrolled laughing or crying, sometimes in context with the situation, but sometimes not. It can be very distressing. You're watching a commercial on TV and you start crying and you just can't stop for 20 minutes. It can be very embarrassing and it can be very isolating for both the patient and the caregiver. We use Nudexa to treat it, and it works very well, and it also has a side benefit of impacting swallow. FTLD is frontotemporal lobe dementia, which is really a terrible concurrent condition that happens with ALS. It's a cognitive impairment that affects everything that this person with ALS does. It can affect any or all of their reasoning, their insight into deficits, their judgment and decision-making, their ability to perform multi-step processes. Can also increase disinhibition, causing personality changes and affects relationships negatively. I've had multiple patients, multiple patients who have come to us who are ready to be divorced because of this type of dementia. They just are not managing the relationship well. They don't understand why their person who has just a weak leg is suddenly completely different. It can be very distressing and terrible until you know that it's coming from the ALS, and until you understand that the ALS causes it, because a lot of people don't really get that. Increasing caregiver stress is a huge, huge deal, and it can be very, very subtle. So this was a quote I saw actually last time I was in Pittsburgh down at the Strip District. The definition of love is being willing to die for someone that you yourself want to kill. And that is really can be how these spouses and caregivers feel about this person, because they can't help it, but it can be extremely, it's very stressful. So veterans, I just wanted to teach or touch upon veterans. I noted before that that's one link that they've found. So veterans are twice as likely to get ALS than anybody who's not served in the military. Once they're diagnosed, they are 100% service connected. And that means that they can have anything that they need, medications, equipment, treatments, everything can be done by the VA. And the VA can be used as a primary or a secondary insurance. It can be used with their secondary insurance. They don't have to just use the VA. They're eligible for lots of benefits like modifications to their homes, power wheelchairs, and a van. And then probably the best benefit overall for caregivers is that they are eligible for a monthly stipend of up to $4,000. It was just changed. And that is meant to make sure that anything that they need that is not covered by insurance gets paid for. We find typically people use that for in-home health care. I just wanted to touch really quick on our interdisciplinary clinic. That's just a picture of the outside of the ALS Center. We are not multidisciplinary. I guess we are, but we act as an interdisciplinary clinic. We typically see patients either together or we see them one right after the other and then concurrently, so that the nurse, the social worker, the doctor, the therapist, and then anybody else who, caregivers, whatever, who want to be a part of the session, we can all draw on our individual expertise and kind of work off each other to discuss why the spasticity management medication is super important, or why they should be using the respiratory device. We find that it works a lot better that way than just seeing the patient one after the other. So they go to me, then they go to the doctor, then they go to social work. When everybody hears what the patient's saying at the same time, everybody can have their own take on it, but everybody also can interject and sort of feed their knowledge off of each other. It works great. All right, so this is the part where I have very little official references, and most of it's directly from my clinical experience. Again, this comes from the document that I have, and it's way more detailed in the document. So let's talk about pain. I firmly believe that no one with ALS should have pain, and no one needs to live with it while they're dying from ALS. ALS is not a condition that causes pain, and if you're not asking your patient, whether you're seeing them at home or as an outpatient or in the hospital in rehab, you need to ask, because they don't necessarily speak up about it. We typically will treat someone with pain meds and then figure out what's causing it. Positionally, if it's an orthopedic diagnosis, then we definitely treat it with typical therapy. We manage spasticity with meds. And I just wanted to put in here that a lot of people want long-standing, especially caregivers, passive range of motion for spastic joints, but it does not manage pain or spasticity the same way a medication that gives you 24-hour coverage will. So if you're a therapist, you can use spasticity as a reason to continue seeing someone, because it's going to help with shortened tendons or tight joints, but it's not going to change the it's not going to change the spasticity itself. That's coming from the nerve insult and the disease. Marijuana is great. We talk about Epsom salts, magnesium oil, tonic water, because it has quinine in it. Any topical treatments, you guys know how to manage pain. I just wanted to make sure I touched upon it. And then educate your patient on subluxations. You know, subluxation will not cause pain until you do range of motion into that above 90-degree range where you're now constricting or pinching or twisting or, you know, getting the joint capsule, whatever. Just stop moving into passive range or range of motion with dressing or whatever they're doing in order to stop the pain. Okay, the hypermetabolic state of ALS is something that not a lot of people know about, and we find ourselves educating every patient on. So there's a beautiful picture of peaches, homegrown, organic, fantastic, and that's what everybody thinks they need to eat, but that's not giving them a lot of calories. It's not giving them a lot of protein. All it is water and some sugar. Nothing wrong with the sugar, but the state of increased rate of metabolic activity is really what they need to be aware of. And we always say, you sitting there are burning more calories than I am just because you have this condition. And then when you take into account how hard it is to walk, or how hard it is to get through your daily activities, how difficult your breathing is, you're just overexerting and using a lot of calories. And then if you add into it swallowing and speech and chewing issues, then you're just making it difficult. So we tell them, again, everybody thinks fruits and vegetables are great. They're great for you, but they're not great in terms of giving you the calories you need. So we tell them they need 2,500 to 3,000 calories a day, full fat foods, and be aware of how much energy they're using during the day. Falls, we'll talk quickly about falls. This is one of my favorite bar sides. If you read the can the guy has, instead of saying off, it says on, clearly not really evaluating the situation. So you need to evaluate why your patient is falling. Do they have foot drop? Do they have hip weakness and not foot drop, quad weakness? Is their balance due to core and trunk muscle weakness, muscle imbalance in their arm? Maybe they have a flaccid arm. Maybe their head's heavy and weak. Do they have spasticity, which is overriding their ability to functionally use their muscles? Are they over fatiguing? Are they not using their respiratory device and thus not, pushing out all the carbon dioxide and getting good oxygenation? So lots and lots of strategies for helping with your falls, but you really need to figure out why they're falling first. Make sure they get an AFO, make sure they wear the AFO if they need it. Make sure they're taking their antispasmodic meds around the clock. They can't just take it PRN. It only stays in the system 4 to 6 hours. Educate them in energy conservation. Talk about safety with gait belts. Try really hard to tell people to not walk unsafely. I know we all see it, but if you think back to what I said about falls earlier and how a sprained ankle then can exacerbate the ALS in that leg, they may never recover and may never be able to functionally walk on that foot again. Respiratory impairment. This is always the ultimate cause of death in ALS. So we use the Trilogy, although I know there's been a recall on that, but the Trilogy can be used as a ventilator. It can be used as a BiPAP or a CPAP, and we use it because it has so many different settings. And we encourage our patients to use it during the day too. Something that we have to educate everybody on is that it's not that you can't oxygenate. Getting oxygen from the air is a passive activity. What our people can't do is use their diaphragm to push the air the carbon dioxide out of their body, which then if you have too much carbon dioxide, you are taking up the room in your cells that would normally use oxygen. It's consumed by the CO2. We will, when we see them, we usually do a CO2 reading on our patients too, but it's something they just don't really understand. So using an assistive device, a respiratory assistive device, can help their diaphragm weakness, and they can feel a lot better, and then they're at less risk of fall, and they have better ability to complete their ADLs. And then I talk about education and head drop. Those are two things that are important to pay attention to. Sleeping is huge, of course. Breathing is super important for these people. Most people who have ALS don't really have asthma issues, but I just wanted you to have a little laugh while you thought about how important it is to talk to your patients about the respiratory status. Along with that is fatigue, because your respiratory status affects your fatigue too. So of course, overall fatigue could be a weak diaphragm and retaining CO2. It can be related to poor sleep. So you really need to educate your patients on their sleep and how well they're doing and how comfortable they are. If they're having pain at night, maybe they're so weak they can't turn over or roll at night, and they need a caregiver to get them to roll them every 2 hours because they're uncomfortable. Maybe they have anxiety and they're not sleeping well that way. So you need to talk to them about it and ask them what is really causing that fatigue, or problem solve with them. So I always talk to my patients about having their own barometer for what they can do, and is definitely not really related to their prior physical fitness. I mean, sure, somebody who's super active is going to be able to do more typically, but not always necessarily. So you're going to assess what their quality of life indicators are. Some people really want to be independent with bathing and dressing and getting themselves out of bed and doing everything on their own. Some people, that doesn't matter as much. They want to be social, so they want help getting up and getting dressed and getting moving for the day, so they have more energy later when they're having lunch with friends or whatever. So don't make assumptions for what your priorities are for the patients or what you think they want. Ask them. When somebody has poor sleep, we talk about things like melatonin. We consider increasing their baclofen or the gabapentin, which are the two anti-spasticity nerve medications, because they both can cause fatigue. We talk a lot about their mattress and how well that supports them. If they have a lot of muscular atrophy, their mattress may be absolutely fantastic, but just not good enough for them anymore. So we'll suggest getting a new mattress, a different mattress, a memory foam mattress pad for the top. Lots of times we talk about not buying a whole new mattress, but buy a new bed, an adjustable bed, or if they want, or they don't have the resources, a hospital bed, and then they can purchase their own mattress for the hospital bed. Having the ability to raise your head up, raise your feet up, change your position multiple times throughout the night with a very little effort can be very good, just to help you sleep better, and it can help reduce anxiety while sleeping. And of course, trying to use their respiratory devices while they're sleeping. So here's the part that I know people are going to have a little bit of an issue with, because I see it all the time in my practice and I have to talk to therapists a lot. Overexertion is extremely detrimental to someone with ALS. In general, you should be discharging or not starting any strengthening or resistance exercises for any muscle group that has weakness. So basically, if you think about how a muscle builds strength, the muscle is torn down with overexertion. You cause micro trauma to the muscle tissue, which then sort of stimulates the regrowth in a larger sort of capacity. That does not work when the nerve is not innervating that muscle or that muscle group. So if you see someone with ALS and they have foot drop, that means that those nerves are not working and you cannot get that strength back. Overexerting those are going to be contraindicated and make the weakness worse. The one sort of thing that you can do is if there's a muscle group that has been unaffected, such as maybe they have upper extremity weakness, but their legs seem fine, you can work on leg strengthening, but just be aware of the overall fatiguing you're doing. And also don't work on the arms because the arms are impaired already. And also remember that no matter what they do in therapy, everything else they do during the day takes their strength, their energy, their impacts their respiratory status, and can be considered an overexertion for them depending on what else they're doing. So I always talk about this at with my team, and I'm trying to be very direct because I don't want to beat around the bush with this, but therapist errors. So there's my little monotony breaker. Sometimes we make mistakes. We don't see people with ALS. It's a rare condition. You may only see 1 or 2 people in your career. Maybe you're close to a treatment center and you see a lot, but these are the caveats. Remember that falls are very frequent after therapy. The same day, getting back into the house, getting up to bed at night because they're tired, or the next day because they're over fatigued from what they did in therapy. Just remember that the therapy they're doing with you is not the only therapy they're doing all day. All the rest of their ADLs are their therapy. And just try not to fatigue your patient. And also remember, it just occurred to me, I should have put this in, they may not tell you that they're falling. They may be invested in therapy and you may not know that they have fallen until a caregiver comes with them or you receive a phone call later. I know that this seems really counterintuitive, but I have been treating patients with ALS for 28 years and I see them month to month to month to month. And I see the long-term effects and how detrimental it can be, even if it doesn't feel like or seem like you're overexerting your patients, and even if they feel like they're really invested in it. So if there's a muscle group that's completely unaffected, you can work and strengthen those muscles if you want to, if the patient is sort of focused on that, or that's their preference and that's where they find quality of life. Okay. So now we're going to go on to numbness and tingling. This is just a picture of an 8-year-old child sleeping on his arms. Any of us sleep like that all night, we're going to be done. And that's one of the problems with ALS. If you can't change your position, that can be it can be a problem. So just be aware of if your patient has numbness and tingling, what's causing it. Are they leaning on their arms all the time to stabilize their trunk? Are they leaning on their arm while they're hanging out in their recliner chair? Are their lower extremities in a dependent position all the time? Do they already have undiagnosed underlying nerve injuries? And occasionally, very occasionally, you can see sensory nerve involvement in ALS. And then talk about position changes in the wheelchair. Talk about edema and how to manage it. Try to cushion those areas that have atrophied. Try to compensate other ways for trunk or leg weakness. And then unfortunately, typically the sensory nerve paralysis will go away with the continued progression of the disease. Here's another monotony breaker. If you get it, rock, paper, scissors. All right, so I did the bathroom modifications, CE, right before this, and it was great. I don't want to talk too much about this because all of us are pretty smart with that. And if you want to delve into it more, I know that we all have access to those. So I would encourage you to look at the, I think it's called Bathroom Modifications, the Good, the Bad, and the Ugly. The one thing I will say with ALS, it's a fantastic bathroom for someone with ALS. But just be aware that not everybody needs a bathroom like this. You have to anticipate the disease progression and then the actual need. So think low cost, low effort first, some basic mods, and then see how the disease is progressing. So again, same sort of thing. This is not one bathroom fits all. This is not, you have to have this good ramp versus that terrible ramp. ADA is not 100% accurate for people with ALS. You have to fit the modification to the patient. So this is sort of a basic progression needs algorithm. If you have lower extremity onset, think sort of like a spinal cord injury person, you're probably gonna be using a power chair unless there's major respiratory involvement. If you have upper extremity weakness, it's kind of like the man in the barrel syndrome where they lose all they atrophy across here and they have no real proximal shoulder neck strength. And you may not need any real modifications with that person unless the respiratory system gets very, very involved quickly. If there's only distal upper extremity weakness, it may progress to all four limbs, but just wait. And bulbar onset, think about everything affecting how they breathe. They may not need major modifications, but they may actually need a power chair because they can't breathe to walk. Insurance coverage, this is, I don't want to spend time on this. I talk about it a little more in my document, but some important things to think about with ALS is if you think your patient is nearing hospice, you better order their equipment right away. Get a bed, get a power chair, anything you can do, especially if they have Medicare and a secondary insurance, because after that, it's just hospice and they're not paying for much. We have a loan closet. There are local loan closets available for people with ALS. Look around. In my document, I have lots of suggestions for where to look and where we have things, and then you can sort of take that and move through that for your area. We're running out of time, so you'll have to look at that joke later. Pressure injuries are important. This picture is just a picture of a baseball hitting an arm and the imprint that was left later. You don't necessarily know what causes a pressure injury, and it may not just be because someone's not moving. You may have somebody who's falling and hitting things. So pay attention and ask about it. The last things that I'm going to talk about before I see we have lots and lots of questions, but typical generalized goals for plan of care. Your plan of care, your goals should all be the same. You are compensating for your patient's ALS symptoms. You are not rehabbing this person. They're never going to get better than they are when they present to you, almost never. So understand the education that you're providing, and you should be providing a lot of education. Help them with independence and ease with ADLs. Increase safety in the home, functional mobility in the community with all their transfers, adaptive equipment. Here's some just suggestions for generalized goals. Promote best positioning and pressure management, psychosocial resources, work with pain, and do an HEP. So when you treat people with ALS for long periods of time, you really start to understand the nuances and how each person is different, but lots of people follow a sort of same progression. So once you start seeing a lot of people, you'll kind of understand how it all kind of comes together. So I know you couldn't interrupt me, and I wish we had been together, but the resources are available, and you can download the handouts. The most important thing that I want to say is to meet your patients and your caregivers where they are that day. understand that they have a terminal illness, and their understanding of the education you gave them last week may be completely different than today. Maybe they're a lot happier, maybe they're way sad, much more sad. You're focusing on compensatory techniques and the goals that that patient wants that day. Okay. So we have some questions. I'll look at the chat. Okay, yeah, all the problems in the beginning, sorry. Okay. The veteran $4,000 stipend comes as soon as someone is 100% service connected with the VA. It's an automatic thing. It comes to them monthly. They do have to actually go to the VA. They have to be hooked up with care. They have to see a primary care physician there. But yeah, they have to, once they do that, they get anything that they'll get that $4,000 grant. Oh, and then Kristen is saying that VA equipment, any questions, you can email her. Head drop through seating. Well, head drop is super important. Yep, somebody else wrote tilt in space. There, unfortunately, I'll implore everybody to come up with a great ambulatory head support brace. I actually worked with an engineering school here trying to figure that out, but it's super, super hard. There's a link on my document for somebody who invented something else. I think it's called the Oscar. I don't even know if it's still in production. It's tough. Oh, there's ambulatory. And yeah, that we use the headmaster collar. That's really the only thing that works. And yes, somebody else said the headmaster, because people with ALS have this sort of, when they have speech and swallowing issues, they don't want anything touching their throat. So the headmaster comes and it's open here, but right, your jaw moves by opening down. And when you have to support yourself on your head this way, it's not fantastic. There's also headrest and power wheelchairs. And then there's also something called the heads up, which goes, it can be a baseball cap, I think. You can strap someone with a Velcro support, sort of like the Whitmire dynamic head support. Headrest. Okay, I'm sorry, I got distracted. The own mattress, we just recommend people get a softer mattress, twin size for a hospital bed. Oh, there's the heads up. That's great. Hospital bed. Sorry, just going through the chats really quick. Quick and relatively affordable wheelchair vans. That is what I found is if you look at used dealers in your area, you will find that there are some people who just kind of like to specialize in that. Also, Craigslist sometimes, Facebook Marketplace sometimes. I've also found there's a website that I think is still available. I haven't looked on it recently, called disableddealer.com. They tend to have some affordable vans. It's, it's hit or miss. Yeah, what is my interval for follow-up for patients? Our patients, we tell them they're usually going to come every 3 to 4 months. And yes, it definitely changes on their progression. If somebody's doing well and they're scheduled for a visit, but somebody else is not, we will call them and ask them if they can wait a week and switch, or if they can wait, until we can get them back in. We can also do Zoom telehealth. We've used that a lot. And so we kind of, we can put off a full in-person clinic visit. I guess the other thing you have to understand about my clinic is that we're a mission-based clinic, even though we're part of a hospital, and every service we provide at my clinic is free of charge. So until they come in to see me for an official occupational therapy visit, they don't get charged for any nursing care, anything I do, anything the doctor does, any information from respiratory therapy or the social worker or the nurse case manager. When they come in for that visit, They are seen for 3 or 4 hours at a time, and I will charge for my visit, the doctor will charge for her visit, and respiratory therapy charges for their visit, and that's all they get charged for. All right, let's see. ALSA can help facilitate, yep. Oh, somebody used disabled dealer in there. Okay, I'm gonna talk briefly about standing wheelchairs. I'm working with someone right now who wants a standing wheelchair. She used a standing, a sit to stand transfer lift for about 4 years. Her ALS is very slowly progressing. And then she got a backlift and pump, and she couldn't use the sit to stand anymore because the presentation of the pump impeded where the the lift sling needed to be. And so she decided, when she and I were talking about getting her a new wheelchair, because it's been 6 years, maybe she should try for standing. And it's been denied 3 times. I went to the coding presentation this morning and didn't get a whole lot of great ideas, but I'm going to talk to the presenter later. There's not a lot of people with ALS do well with standing wheelchairs. I have had people with the VA who have gotten them, but they quickly become unable to use them comfortably because of either respiratory impairment, where it's sort of pressing on your chest to hold you up, or trunk weakness or head weakness. So unfortunately, it's not something that I recommend very often. This specific case, I'm trying very hard to help her. Sliding tub transfer systems, yep. So somebody has written a good article about rehab and ALS. Okay, not sure. I don't know that article, so I can't reference it. Yep, and Permobile has the white paper on standing, but basically because it's group 4, they are declining it, they're denying it. Now, I just saw that Permobile has just made the Corpus, the F5 Corpus VS a group 3. And so that's what we're trying right now. So we'll see how it goes. Time is at 3:08. Okay. Oh, Pam, that's great to know that the Oscar brace is still being made. I would love to hear from you directly, Pam. We spoke via email previously. I would love to hear more about the Oscar brace, and if anybody else does, then maybe we could get into sort of a group email about it. Talking about the standing wheelchair being denied, the other thing that I would say is maybe try to find a standing lift, because of all the issues with the standing chair. A standing lift is something that we loan out of our loan closet a lot. I like the Romedics mini lift the best. Actually, I think it's not even Romedics making it anymore, but it's fantastic in terms of therapeutic standing. And then you can also use it as a transfer system. So you might want to think about that versus a standing wheelchair due to getting it denied. And sometimes ALS progresses a lot faster than you think it will. And then you end up with a wheelchair that has this whole other thing that can go wrong on it that you're not using. Whereas if you use the lift, you can then just move to a Hoyer. Okay. Okay, so yep, David Beals talked about the topic of how important the pelvis is for proper placement. I didn't even approach that today because that's really for wheelchair seating and positioning. I totally agree with you. If you don't start with the pelvis, you're gonna be out of luck. So definitely look and research, just basic conferences. And I'm sure there's things at the ISS on how to get your how to work on positioning. And there's also something on the back of my document, at the end of my document, on positioning. And I'm pretty sure Permobile has some really good animations or comic type handouts. So if you go there, you can get some really great things. Okay, devices for the disabled. The Savant headrest. Yep, it's definitely hit or miss depending on who gets it. Okay. I think we're close to the end because I'm getting a couple of thank yous. So you can contact me afterwards. I really love to share information. I'm sure there's lots of things that I don't know. It's hard to keep up. I'm actually only part-time at the ALS Center because we're mission-based and they can't pay me enough. They don't have the budget. There is a COTA who's there as well, and she's fantastic. So one of us is usually there every day. And my contact information is at the end, or I'm sorry, near the handout. So anytime, please reach out. Any other questions, or I think we're done.
Awesome. Well, I will give you guys all the CEU code. Thank you so much, Susan. That was a wonderful presentation.
Thank you.
So our CEU code for this session, IC23, is UD12TQ. And I will put that in the chat box as well. And then just a reminder for everyone to go on and complete your survey.
Thank you everyone for sharing your knowledge as well.
Righty.
Okay.
Yeah, I think we can stop our recording.